Hi, everybody, and welcome to Healing Arts, Narrative Medicine and Healthcare, presented for the Myopain Conference. Big thanks to Dr. Deepak Sharan and Aditi Bhatt for helping to make this happen. It's such an honor to be here learning with you all today. Just a quick note before we get started about how we're going to get organized today for those like me who like to have an idea of where we're headed. In this 20-minute presentation, I'll mostly be talking at you, which is a very unnarrative medicine thing of me to do. Narrative medicine workshops are usually active, collaborative, experiential, and done live. But I do think some high-level context is helpful in learning about what narrative medicine is and how it applies to your field. But if you'd like to experience a live narrative medicine workshop for yourself, I invite you to check out our website at narrativerx.com to see the upcoming dates. I usually host a workshop a month. And if you'd like to participate in this month's group, just email me at info@narrativerx.com. I'll send you a free coupon so that you don't have to pay the registration fee. You can also email me at any time if any questions come up or if you just like to keep the conversation going. So, in the spirit of context, my name is Julia Schneider. I am a pain management, massage, and yoga therapist. I also own Rise Wellness Center right here in Austin, Texas, where we specialize in treating persistent pain. I'm also a former college English teacher, and I now teach close reading and creative writing to healthcare professionals. I know that at first glance, healthcare and the arts seem like an awkward pairing. But after 15 years of study in both fields, I'm still learning how much they have to teach each other. Because ultimately, pain care is all about stories. Let me tell you why. There is no objective measurement for pain. No thermometer, no blood test, no visual or manual assessment is going to tell you how much somebody hurts. Only they can tell you that. Pain is a lived experience, revealed only through the stories of the one who's living it. Neuroscience shows us that pain is highly influenced by stories too. Personal experiences, beliefs, and expectations, not to mention social and economic resources, are just as relevant to pain management as diagnosis and prognosis. And yet, most clinical education fails to prepare providers to interact with stories and psychosocial dimensions of patients in a meaningful way. You can see from this chart here what we call the biopsychosocial model of pain, which differs from the biomedical model, which sees pain as a product of issues in the tissues, the musculoskeletal body. Biopsychosocial models, however, take into account psychological factors, social factors, cultural factors that can all contribute to a pain experience. The truth is, most clinical education fails to prepare healthcare professionals to interact with stories in any sort of meaningful way, and this isn't just bad for patients, it's bad for providers and hospitals too. When providers lose touch with the humanity at the heart of medicine, they lose touch with their own humanity as well. They too become automatons. According to a report released by the National Academy of Medicine in 2019, as many as half of the country's doctors and nurses experience substantial symptoms of burnout, resulting in increased risk to patients, malpractice claims, worker absenteeism, and turnover. And what's more, about 40% of those surveyed reported feeling depression or experiencing suicidal ideation, which is shocking to me, a shocking number. And this was before the added challenges of coronavirus and the pandemic. By 2021, evidence of burnout was rising, with some 60% to 75% of clinicians reporting symptoms of exhaustion, depression, sleep disorders, and PTSD. But many studies have shown that healthcare providers who read literature, especially fiction, have been found to have lower level of burnout than those who did not report being consistent readers. One survey of 513 physicians examined the impact of non-medical reading habits on burnout. The chances of emotional exhaustion and depersonalization fell as physicians became more consistent readers. When compared to non-readers, the relative risk of burnout For consistent readers, those who read at least one book per month, fell by 19% across the emotional exhaustion domain and 44% across the depersonalization domain. That's astounding. In another study, more than 200 urology trainees were surveyed about work characteristics and relaxation techniques. These included watching movies, meditation, yoga, reading, and other ways of relaxing. Surprisingly, meditation, exercise, and yoga were not protective against burnout, but reading was. I believe this is because reading is not only relaxing, it also builds empathy. It asks us to view the world from other perspectives and to identify with them. Reading takes us out of the world of knowing and into the world of thinking. Narrative medicine turns the usually solitary pastimes of reading and thinking into a community practice, which can be a great relief for physicians and other providers who are expected to know everything already and who often feel isolated as a result. So, what is narrative medicine? For the purposes of this conference, narrative medicine offers a big dose of prevention. It might not prevent any musculoskeletal disorders, but it does prevent burnout. And it certainly provides, to quote this year's Myopain theme, a new way of working. Broadly, as narrative medicine is the study of stories in medical practice, or better yet, stories as medicine itself. Rita Sharon, founder and director of Narrative Medicine Program here at Columbia, puts it even more subversively. I don't know if you can tell how punk rock she is by that sweet picture there, but she is her ideas are very radical. She describes narrative medicine as a, quote, response to a commodified healthcare system that places corporate and bureaucratic concerns over the needs of the patient. In short, the study of stories puts people first, not dollars. And the applications of narrative medicine are profound. As we practice absorbing, interpreting, and reflecting on the stories told in literature and other artworks in private group settings, we are simultaneously learning how to absorb, interpret, and reflect on the stories our patients tell us in a clinical setting, and to be as moved by them. So how do we teach this? I'm sorry to say there are no hard and fast techniques or toolkits when it comes to narrative medicine. There isn't even an agenda. There's only a practice, very much like meditation. Embodied skills like listening and connecting can't be memorized. They take time, focus, and experience. Much like pain, narrative medicine is also an emergent process. It can't be taught from teacher to student. It can only be experienced through relationship. Here's a testimonial from one student that speaks to this. I don't know how I became a better listener. I couldn't put a particular moment or technique on it, but at the end of 5 weeks, I am undoubtedly a better listener. So how do we practice this important skill? Through a process called close reading. This process is something you've probably had a little bit of experience with in maybe a high school English class. But our version of close reading is, I'm going to argue, a much more generous than the kind of close reading that you're typically taught in a high school or collegiate format. And I'll get to that in just a moment. Our method of close reading is focused on teaching healthcare professionals how to listen attentively and generously to patient stories. When all the academic theory is stripped away, close reading is simply a practice of paying attention. And just like there's no one good way to pay attention or one perfect way to listen, there are multiple ways to close read, and some are better than others. So, for example, close reading is always grounded in the material details of the text. And a skilled close reader will notice that particular words or phrases or patterns or tones or even tenses are starting to appear more commonly in a text. And then they use these observations to reflect on the meaning of the text as a whole. The only rule here, though, is to listen, to truly listen to what someone is saying. Or, as we say in close reading, to learn how to ground your observations in the details of the text itself. That way we're not projecting our own stuff onto a painting or a poem or a patient. After close reading, we often find ourselves with more questions than we have answers, and this means we're doing it well. Learning how to craft better and better questions is an especially important scope building tool for physicians who are used to ticking boxes and writing notes in prefab margins. Here are some examples of questions we might consider while close reading. And keep an eye on these questions. Keep them in your back pocket because we're going to be returning to them as we do a little close reading in the next segment. Some examples of questions are, which phrases or images physically grab you, make you feel something, make you want to lean in, make you curious? What is the character here doing? Or in other words, what's the plot? What does the sentence structure or tense tell us about the speaker? So for example, you might notice that a passage is told entirely in past tense, or perhaps entirely in future tense. Or maybe a passage runs on and rambles on very quickly with no punctuation, and what does that do to the experience of time? Or maybe their sentences are very short and staccato. What does that tell you then about that person's lived experience of time? What does the color palette or geometry of a painting reveal? And then I think very provocative questions. Whom do you hear and whom don't you hear in any given text? Let's practice this together. So we're going to look first at a painting by Pablo Picasso called Weeping Woman. Let's take a moment just to sit still and be with this painting. Start to ask yourself what you notice about color, geometry, action, expression, and tone. As you sit with this painting, you might start to notice ways that it speaks to you. Some common observations that I've heard in workshop before are that the color palette is mostly bold and primary. You know, these vibrant yellows, reds, and blues on the outside of the painting, whereas the inside of the painting tends to be monochrome, blue-black against white, almost like an X-ray. Students have noticed also that the geometries here are contrasting. Outside of, on the exterior part of the painting, we have very soft geometries in the hair and in the curve of the fingers, even in the softness of the curtain behind the woman. Whereas toward the inside of the painting, where we saw the monochrome color, we see the geometry become more jagged, almost like broken glass. When we wonder about the action, some students argue that she is stuffing something into her mouth. Other students argue that she is letting something out or trying to. Some people argue that her expression ranges from bored to frustrated to impossibly sad. And they might look at her eyes and the angle of the eyebrows to ground these observations. They might look at the pupils to notice that they look a little shattered or X'd out, almost like a dead cartoon image would be. And we use all of these observations then to speculate about the emotional tone here. What is Weeping Woman seeming to feel? And then what are we feeling as we look at her? And it's in that shared space between the text and the observer or the reader of the text that we start to assemble meaning. What do all these details and patterns reveal about the painting's meanings, and how does it help us understand what it is to be a weeping woman, or what it is to live with pain or suffering? So some students, when they first start working with us, come in with listening that is closed. It dismisses a storyteller, or it reduces a story to a single surface level interpretation. Probably because they've already had a little bit of knowledge of the text or the author or the painter, and so they close off any other possible interpretations based on what they feel they already know. So here's one example of this kind of listening. A student says, "I hate Picasso. He was a misogynist, and this painting is about misogyny." And I'm not going to argue with the student. I'm not going to say the student is wrong by any means. But this student is foreclosing any possible other interpretation or interaction with the text itself beyond the author. Also, an example would be Googling, what is Weeping Woman about? I did that actually, and Google says, this painting is about Dora Maar, one of Picasso's lovers, known for her volatile temper, represented by the glossy black hair, tapered fingernails, and tearful state in which Picasso often portrayed her. Again, reducing this very evocative, dynamic painting to a single surface level interpretation that closes down all other possible interpretations of it. Here, however, is an example of really good listening. A student says, this painting makes me feel sad and angry for the woman. She's clearly suffering. I can tell because of the tear rolling down her cheek. The shape of the lines around her mouth remind me of a broken heart. Oh, let's go back and see that. I bet you won't be able to unsee it now. Do you see how the broken lines around the mouth resemble a heart? How interesting. And how does that change our understanding of her lived experience of pain as a kind of heartache? The way the color changes to an icy gray toward the center of the painting suggests that something is freezing, maybe even dying inside her. So you can see from this example that the student really engages with the text, but she also grounds her observation in the details of the text itself. So she's not just spouting things at random or saying how it makes her feel, although those saying how something makes you feel is valid as well. But I think a more complex and nuanced way to do that is to say how it makes you feel because of the details presented in front of you. That way other people can see it with you as well, just like we saw with the heart. As you can see from these examples, close reading teaches providers how to listen for the details. We practice getting curious about the nuances of artwork so that we can strengthen our curiosity for the details of communication in the clinic as well. The kind of reading we learn in narrative medicine is not just about efficiency, it's also a practice of generosity. When I was in graduate school, I learned how to think critically, which is a very important skill, especially in today's political climate, but no less important than reading and thinking generously. When we listen for mistakes, for gaps in logic, places where we can insert our own voices, we often miss the point of the story altogether, or we miss the good details that tell us even more. Instead of thinking against, narrative medicine teaches us to think with, to put ourselves in others' shoes, and to do our best to see things from their perspective, even as we acknowledge the fact that we'll never completely understand what someone else is going through. This kind of listening is not a one-way journey either. The closer we attend to other stories, the better we understand our own. As one of my narrative medicine teachers from Columbia, Craig Irvine, puts it, in listening for the other, we listen for ourselves. Here, however, I should add an important caveat. The last thing that I want you guys to take away from my presentation today is that narrative medicine will teach you how to close read a patient like an object or like a book. A patient's living embodied speech is not the same thing as words on a page, and it should not be treated as such. We wouldn't just listen to a patient's story and proceed to tell them what we think it means, given their narrative choices and word choices, and then walk away feeling like clever close readers. When we're working with patients, rather than printed story, we have the privilege of asking people to clarify or correct our understandings. Of course, this begs the question, why are we studying artwork in the first place then? Why aren't we just practicing real conversations that might come up in the clinic? Close reading in artwork, I'm going to argue, allows us to hit the pause button, to delve into all the layers of a textual present, and to hold its individual details up to the light, to really examine through slow time and to sink in and to begin to wonder, which is such a luxury for those of us who are used to the fast time of the clinic. When we're dealing with patients, we have thousands of these moments to consider in a single encounter because with each moment the story changes. But here, as we look at artwork together, we have the luxury of slowing down and existing in the pure present of a text, a practice that we hope will serve us in the real time of the clinic and in the world of our personal lives. Finally, after an in-depth and collaborative close reading, a traditional narrative medicine workshop ends with an opportunity to brush our own self-stories up against the artist's story. We call this writing in the shadow of the text after it's had a chance to work on us. I usually give the group a prompt inspired by our discussion of the artwork. So I've used Weeping Woman several times in the past, and each time I use it, a new prompt presents itself depending on our discussion. And then the group has 5 minutes to respond to that prompt in writing any way they like. They can respond with a general reflection, a true story, a made-up story. The prompts are intentionally vague to allow lots of space for interpretation. We're going to try this out together now. So go ahead and find a pen and paper. Consider the following prompt inspired by our discussion of Pablo Picasso's Weeping Woman. Where have you seen this face before? When you're ready, hit the pause button on this video, set a timer for 5 minutes, and free write. And I'll give you a little word to the wise. Don't try to write well, just get words on the page. Don't worry about trying to sound clever. One of my favorite teachers always said, writing is a way of learning what one knows. So find out what you already know. Hit the pause button now and get started. All right, if you took the time to write, welcome back. If we were in a live workshop, this would be the time that we would break into small groups and to share our writing and to reflect on each other's writing with the same generous attention to detail that we gave Pablo Picasso and Weeping Woman. So if you'd like to share your writing with someone, please don't hesitate to send it to me at info@narrativerx.com. I will reply with a close reading of your work. Forgive me if it takes me a day or two to respond, but I promise I will get back to you with a close reading. I think it is such a gift to truly be listened to, and I'd love for you to experience that firsthand. So since we're not able to meet in person, please send me an email with your close reading, and we can get a close reading and a conversation going. We always end a workshop by asking students to tell us in 1 or 2 words how they feel after all this listening and writing and sharing. Words that usually come up are held or seen or cared for, sometimes even relieved. These feelings are what inspire us to pay listening forward. Compassion, or what Rita Sharon calls affiliation, inevitably develops between a storyteller and a listener as a result of true listening and generous reflection. If you're interested in learning more, please join our group Facebook page called Narrative Medicine and Pain Care, and meet a really exceptional international team of healthcare providers, patients, teachers, scholars, and activists who are all doing amazing narrative work in their own communities. Also check out our website at narrativerx.com for upcoming workshop dates and information on private coaching. It was a pleasure to speak with you all today. I sincerely hope to meet you and to hear all of your stories very soon. And for those of you who are curious, these are some of the references or sources that were cited during this presentation. Thanks so much, everybody. Have a wonderful conference. Hope to hear from you soon.